ahead and get started. It is noon on the dot. My name is Laura Evans. I'm the Director of National and State Policy with Vibrant Emotional Health and Vibrant. We are the current administrators of the National Suicide Prevention Lifeline, and very proud and pleased to do so and work in partnership with SAMHSA for that. And so today we are talking about the moment that we are in and meeting it with Medicaid and Medicaid funding sources. So very excited for this conversation today. And if we go to the next slide, we'll kick us off. So as you know, the 988 Crisis Jam has grown quite a bit in size, and we are currently up to 61 national organizations, in addition to representation from every state in the mental health offices, and seeing Medicaid offices joining us as well, and hope more will join us because they're an important part of this conversation. And then we're also seeing our fellows who are doing this work in other countries join us, and hope to learn from them and share ideas as well. So next slide. Yes, and if you are not listed, if you are a part of a national organization that has not been listed on that slide, please email Karen. She put her email in the chat, and we will make sure that that is updated. And so another kind of landing page for us here, if you ever need to refer to information that you heard in the jam, feel free to go to talk.crisisnow.com. And here it's a lovely landing page. You can easily access the Zoom link. You can watch past videos. You can sign up for the newsletter so that you don't miss any information. And if we go to the next slide, I'm going to tell you about an update to the jam, and that, or to this landing page, and that the videos from previous weeks are now hosted on YouTube. So this makes it easier to access if you are watching online, and a little easier to share with your colleagues. Although I would also encourage them to sign up for the newsletter and join us here in person on Wednesdays if they can. So this is really exciting. We hope that this will be more helpful for folks to, as you try to digest all of the information that we share every week. Just know that you don't have to remember it, and you can just come to talk.crisisnow.com. So if we go to the next slide. The quote of the week comes from Dr. Robert Williamson, who was a featured presenter last week. And this quote kind of really talks about how we can best utilize no wrong door approach without necessarily having a medical clearance. And it's really all about controlling our fear, as Dr. Williamson noted, and he noted as it relates to the importance of crisis receiving and those providers. But I think that also applies to industries across the field, particularly in the policy space where I sit. You know, it's really important for us to control that fear and lead with hope. So thank you, Dr. Williamson, for this quote. We're going to move to the next slide. This has been a very busy week on the Hill for mental health. There's been a number of hearings. So I just want to acknowledge some of the hearings that have occurred. There's been mention of 988 throughout almost all of the mental health focused hearings, and also want to give a large kudos and shout out to the Centerstone team with Dr. Lockman, Becky Stoll, Lauren Conaboy, just leading great work across this crisis continuum, making sure that we're all thinking about it through a connected and coordinated lens. So next slide. And of course, the Surgeon General expressing his support. Next slide. And of course, the finance meeting also had a second follow-up hearing recently. So we'll be sure to have that information for you. If we go to the next slide. Great. So at this point, I want to get into our featured presentation because I think it's going to be really interesting for everyone. And it's about Medicaid's role in building comprehensive crisis care systems. So I'm going to turn it over to Vikki Wachino, who is the principal from Viaduct Consulting. She's the former director and deputy administrator for the Center for Medicaid and CHIP Services. And I think this is a very important conversation. So I'm going to take lots of notes and turn it over to Vikki. Vikki?
Laura, thanks so much for inviting me today. It's great to be with you all. My presentation is really focused on how to use Medicaid to build a comprehensive system of crisis care, leveraging the opportunity that's created by a new incentive to provide Medicaid mobile crisis services. My presentation is predicated on two assumptions. One is that Medicaid is the most promising avenue for sustainable financing for crisis and other services. And that is because Medicaid provides a guarantee of coverage and is a large coverage source serving some 80 million Americans right now. So it's one of the major sources of financing for all health services in the United States. And its comprehensive benefits and guarantee of services to people who meet the eligibility criteria mean that it is a sustainable financing source that everyone can have confidence in. And the second assumption, which may be less obvious, is that Medicaid is now and has consistently throughout its history been turned to as a way to advance national goals. So over its 57-year history, Medicaid has supported national objectives that are as diverse as helping to promote readiness and fitness for military service in the Vietnam War, which was a time at which Medicaid's comprehensive pediatric benefit was established for that express purpose, to more recently helping to drive a rebalancing in services that are provided for long-term care, rebalancing from institutional to home and community-based care. So if you looked over the course of time, you would see that there have been many groups like the crisis community that have asked themselves the question, how can Medicaid fit in and how do we really leverage Medicaid to support our goals? And this is a community that is working to try to expand access to behavioral health driven crisis services to meet people in their most vulnerable moments and to try to unlock and undo our history of meeting people at this time of vulnerability in hospitals, in jails, in emergency rooms, to promote people's health and wellness. So I invite you, as you're doing work as providers, as governments, as communities, to really think, as the illustration on my title slide suggests, of Medicaid as being one part that fits and interlocks with other pieces to help achieve the goals that you are seeking. So with that somewhat lengthy introduction, we can go to the next slide. My presentation is going to focus on, what are the ways in which we can leverage Medicaid and use Medicaid to help advance crisis services. And this will be a high-level overview and is really designed to frame up for you a series of 3 reports that I've done with colleagues over the course of the past year to help advance understanding of the ways in which we can leverage Medicaid to serve these purposes. So I'll walk through the slide deck, and at the end, I will make sure that you have the resources you need to take a deeper dive. So just digging in, this slide is just a level set, and the formatting came out a little bit differently, I think, from the way in which it was sent. So apologies for the heading being on the side, but hopefully people can tilt their heads a little bit and read it. Medicaid is a major source of financing for behavioral health services in the United States, and accounting for about $1 in every $4. It serves about 1 in every 5 people with a mental health issue, and also plays a huge role for people with substance use issues. So it's a natural place to turn to. It offers more comprehensive benefits than commercial insurers when it comes particularly to behavioral health. So that makes it a potentially strong platform. But here's the but. But at the state level, there's a lot of variation throughout the Medicaid program, but particularly with respect to the type and extent of behavioral health services that get covered. Many behavioral health services are optional for states to provide. And if you look both at the continuum of crisis services and behavioral health services more generally, there are opportunities to expand the comprehensiveness and reach of behavioral health services. Next slide. As you're thinking about how to leverage Medicaid for the purpose of expanding crisis services, you might be challenged if you're looking at Medicaid policy to find the levers. But as it turns out, there are many different ways to cover crisis services through Medicaid. I had the chance last year to inventory some of them in a report that I did for Wellbeing Trust. And there are basically 5 different categories of services, none of which are labeled crisis. So you have to look for them a little bit, but there are ways that you can expand optional benefits, including Medicaid's rehabilitative services option to cover crisis services. That's a very commonly used approach. Home and community services for people with disabilities and seniors is another avenue. States can and do rely on managed care to organize their provider base, and that also provides a degree of benefits flexibility, particularly when it comes to crisis services. And states can also build comprehensive continuums of behavioral health care that include both community-based care, emphasize crisis services, and provide authority for coverage of residential services. So those are 4 different avenues of service provision. And although most people do, and it's right to think of Medicaid as primarily funding services, I think it's also a great time to acknowledge that Medicaid also plays a role in funding some administrative spending, as well as some information technology spending. So as people are working at the state and local level to expand, to stand up 988 call centers and to expand the reach of warm lines and other services, Medicaid can fund parts of those functions, both from an IT perspective in helping with the systems build and operations, and from the perspective of just the ongoing functioning of crisis call lines. There are limits to what Medicaid can pay for. It can only fund the share of those services that can be attributed to a Medicaid eligible population, but it's there as a financing source. And I think that when you think about the challenge of comprehensive financing for 988 services, it's a tool that's available and could be leveraged. Next slide. And I'll say, although most of the rest of my presentation will focus on the opportunity that's presented by the Medicaid mobile crisis implementation, the slide I just showed you about the different ways of authorizing crisis services really is the crisis service ballgame. Mobile crisis, while important now and in the future, is a relatively narrow slice of a broader continuum of crisis services, not to mention the value of adding and expanding access to community-based services that can prevent people from needing crisis services to begin with. Congress in the American Rescue Plan that passed just short of a year ago wanted to incentivize behavioral health-led approaches to people who were in crisis. Mobile crisis in Medicaid is not new. Many states have done it for some time, but Congress looked at the challenges we were facing as a country with lack of access to behavioral health services and a degree of reliance on law enforcement.
I see you're doing children and LGBT.
I think people could mute their phones. Thank you. Congress decided to incentivize multidisciplinary teams led by behavioral health professionals that respond to people in their moment of crisis in a way that emphasizes de-escalation and trauma-informed care. Congress felt strongly enough about the need for this to attach a powerful financial incentive, which is an 85% matching rate. And these new programs can start as soon as April 1st of this year. Next slide. CMS issued late last year, just before New Year's, implementing guidance with respect to mobile crisis services, and that will be the subject of my next slide. And I just wanted to highlight a few of the things in the way in which CMS prioritized its take on what's valuable in terms of crisis services for states. The first is that CMS and SAMHSA seem to be working pretty closely together, which is fantastic. And in the guidance reflected input from both CMS and from SAMHSA. And the two agencies really used the guidance as an opportunity to make sure that the field is aware of the ability to think about Medicaid mobile crisis and fund Medicaid mobile crisis at the same time, and leveraging the ability and availability of block grant resources like the mental health block grant. So in the field, it's very common to talk about braiding funds. And I feel as though CMS and SAMHSA really encouraged that in the guidance. CMS was also very clear that as we build Medicaid mobile crisis programs, these are programs that are meant to respond to both mental health and substance use emergencies. And I felt like the agency was very unequivocal in that point, although I'm sure we all recognize that the field has some growth to do in integrating the availability of those services. CMS also pointed out what I said earlier, which is that administrative funds are available to fund call lines and other services. And they also took the added extra step of just synthesizing best practices in mobile crisis response, whether a state is going for the new mobile crisis incentive or not. And we expect at least half of all states will do that. CMS made available as a resource for the many people in the field who are working on mobile crisis, its take on what's proven most effective over time. Next slide. So knowing that the Medicaid mobile crisis incentive implementation would be very active right now, I joined with partners at the Technical Assistance Collaborative to produce 2 reports, and we really approached the work from the standpoint of how do we make the most of this opportunity of building Medicaid mobile crisis in the best way possible, and also to establish these services as something that interact seamlessly with 988 and help build towards a broader continuum of care. I know at least one of my co-authors on this report, Jordan Gully, is on the call today, and I was delighted to have a chance to work with her and Kevin Martone and John O'Brien. And we took the question from 2 angles. One is, what were the strongest and highest impact approaches at the state level to Medicaid mobile crisis implementation? And then what could be done at the federal level to really advance strong and robust crisis continuums that include Medicaid mobile crisis as a part? We interviewed 5 states for the state report: Arizona, California, Georgia, Massachusetts, and Washington. And this slide is just some of the takeaways we had in terms of best practices. The leading states were clearly focused on integrating mobile crisis with call centers. So focusing on that front end of crisis response, but also thinking from a systems perspective about how you used crisis as an access point and an on-ramp to services, as well as how you expanded access to community services in the moment pre-crisis. Clearly, any conversation about behavioral health right now, in any conversation, the challenge of workforce is front and center. And that was absolutely true of the 5 states that we talked to, although they were energized and excited and thinking really thoughtfully about how to either expand existing programs or build new ones. They all recognized the challenge that we face on the workforce front right now. And we're deploying strategies that included standard setting and training to try to do what they could. And I'll go to the next slide now and just briefly touch on the federal recommendations before we open this up for questions. At the federal level, we identified 2 potential avenues, an executive branch avenue and a federal legislative avenue. So at the federal level, we saw opportunities for CMS, SAMHSA, and some of its sister agencies to really encourage the use of temporary increases in home and community-based service match rates and CHIP health services initiatives to be part of the financing equation, to establish measures of effectiveness of services, and to work with states to promote a full continuum. And I should say, those are all ways that CMS and SAMHSA and other agencies can provide encouragement. But don't read that as saying that you have to wait for CMS and SAMHSA to do these things. Many of these are approaches that states and communities can undertake now. And then I'll just wrap up by saying we also wanted to put some ideas in front of Congress so that Congress could, if it wanted to further advance crisis service provision, take additional action. One of the most far-reaching recommendations is that Congress expand the ability of both private insurance and Medicare to cover crisis services so that Medicaid isn't bearing a disproportionate load of helping to finance these services. And because we recognize that having commercial insurance in Medicare is really part of creating an ongoing sustainable financing and coverage source for crisis services. So there are a few other recommendations I'll leave for you to read. And then if we just go to the last slide, it will show you where to go to find these 3 reports, the first done for Wellbeing Trust and the second 2 done with the support of the wonderful people at the California Healthcare Foundation and the Schusterman Family Philanthropies. So Laura, I'm happy to spend a few minutes taking questions if people have them.
Perfect. Thank you so much, Vikki. This has been really helpful. I've been taking a lot of notes and there's been some really good questions in the chat. So before we move to our roundtable, perhaps, just taking one question from the chat related to any words of wisdom for incorporating reimbursement for children crisis services.
Sure. I mean, children occupy have a very favorable benefits package that gets under recognized and potentially underutilized when it comes to crisis. So first of all, kids have the most comprehensive benefits in the Medicaid program. Medicaid guarantees a comprehensive benefit package, which has a long and awkward name of EPSDT, the Early Screening, Diagnostic, and Treatment Program. But it was developed and established by Congress to meet all of kids' health and developmental needs. So I think the first thing to know is that when it comes to crisis or any other behavioral health services, there is an assurance and an expectation that kids get the services they need. That obviously, Laura, can translate into payment, right? You have to pay right for the right kind of service, which I think goes to the heart of the question. And I think that, in the report that we did with TAC, we identified opportunities to develop episode-based payments and other flexible payment approaches to really start to foster holistic approaches to the health of kids and other beneficiaries.
Great, thank you, Vikki. So at this point, I'm going to open it up for the roundtable discussion. And for that, I'm going to bring in Dr. Ward from the Virginia Department of Medical Assistance Services and Dr. Insel from former director of NIMH from 2002 to 2015. So Dr. Ward, let's start with you. Any thoughts on the presentation?
Well, as always, Vikki has done a wonderful job of, really highlighting some of the things to keep in mind when bringing mobile crisis online. For Virginia, we were in this kind of serendipitous position where we were moving towards mobile crisis and a whole set of crisis services prior to the pandemic, and really were kind of in motion, and we kind of pre-submitted our SPA, we were ready to go. And so while the money that we had from our General Assembly to do that was on pause for a bit at the start of the pandemic, it was reallotted and we were able to move forward. So we actually launched a whole set of new crisis services on December 1st of last year, so 2021. And, just for context, in Virginia, we did choose the rehab benefit route in terms of bringing mobile crisis into play. And we, like many other states, had technically some mobile crisis happening, but in Medicaid, we weren't defining it so explicitly as we could. And so in this process, what we did was bring on mobile crisis with a variety of different approved teams, going back to one of Vikki's important points about integration of peers and folks with lived experience, and really considering the workforce crisis that we all share. So, we made sure to allow for a wide variety of different teams to go out. And then again, serendipitously, COVID provided us with a huge boom in telehealth technology that we just didn't have prior. And so it allowed us to open up and think about different options for extending the workforce through telehealth. For example, having, supervision over telehealth, having tele-assisted assessment and supervision, where we have an LMHP on a telehealth device when others are out doing the mobile response. And so we were able to get a bit more flexible and creative to work with the workforce that we have and the ongoing pandemic and our mobile crisis teams. So we brought in mobile crisis in that way, and of course also had accompanying services to go with it. So we actually went with the option in Virginia to create a service that we called community stabilization. Now we had we had crisis stabilization before, but the way that it was defined was very broad. And that same service was being delivered within the community as well as in facility-based residential crisis stabilization units. And really the reimbursement structure was fairly problematic because it was an hourly structure. And so we moved to, again, just better define everything and make it very clear what service was what. So the community stabilization service we saw as a really big need in Virginia just because of a lot of our access to care issues here in our state. So this provides what I refer to as the long hand hold. When there isn't a service immediately available for opening, once a mobile team has been dispatched, they're able to offer this community stabilization services, that long hand hold, the warm hand hold to get them over to that service when it becomes available. And we have seen a large and fast uptake of that service, which really didn't come as a surprise to us given access issues and workforce issues in the pandemic. And then we brought on.
Sorry, Dr. Ward, just wanted to make a connection to the presentation as well, because I think the definitions and the workforce and integration piece Vikki all mentioned, and I think that's so important for states to get. I also want to bring in Dr. Inselt and get your thoughts as well here.
Yes, please.
Well, thanks. And thanks for including me in the conversation. I know it's always so important to focus on Medicaid and what they can do. And there's no one better to do it than Vikki, because she's really the nation's expert on how to use this and how to navigate this. We've got a lot of people on the line here in the JAM who are state Medicaid experts and who have struggled with various parts of the different waivers to be able to use Medicaid. But I think just to go back to her first 2 points, because I think they're the most critical things for all of us to remember. This is the 800-pound gorilla. This is the biggest provider of mental health services in the United States. $68 billion in 2019. I think it's gone up since then. It's 30% of all mental health funding, and it is sustainable. the words she used, I think, are really important. It's a guarantee of services. We don't have to worry about discussions on parity when we're talking about Medicaid. It's a different animal than the commercial sector, and it's a very it's the most important one for us to be talking about because it's sustainable. It's not grant driven. It really is driven by these waivers, and it's up to the states to then get smart about how to use the 1115 or other waivers to be able to get the services that every state needs. The second point that she made, I just can't stress enough. We're at a historic moment here. This is a real transitional point. We started off, talking about the Senate Finance Committee and the Health Committee and how members of Congress in a bipartisan way are looking at mental health as the issue as we come out of COVID, and crisis services are a huge piece of that. CMS has always been in the business of driving policy for the nation by moving money around. They're really good at that. And they've done that in many, many areas, but actually not so much in mental health. And that's beginning to happen. And it's really shame on us if we don't take advantage of this moment to use the sorts of resources that Vikki outlined to be able to apply them. Just like one quick example, and then I'll shut up. And that is, we're very focused on the mobile crisis piece, and we should be. That's like really interesting, 85% match, and lots of opportunities there to take advantage. But she also mentioned the 988 service itself. I mean, all of us have been thinking about that as kind of like 911 for mental health or for substance use disorder. That's wrong. This is not 911. This is telehealth. These aren't just dispatchers. These are first responders. And Medicaid has a very important role in supporting what they do. Now, thinking about how to do that, how to access it, how to drive that support, it's not simple, but the opportunity is there, and it's absolutely the conversation we should be having before July.
Thanks, Dr. Ansel. That's such a great point. And I don't know if I want to call it too early, but I think you may have just had the quote for next week, because it's so important what you just mentioned around CMS and the reimbursements helping to drive and set policies. So I think that's critically important, particularly as we talk about the crisis centers and the work that they do. And it's not traditionally reimbursable through other mechanisms. And so how can we pull these levers to make that happen for the great work that they do in diverting from the need of further interventions or perhaps more intensive interventions is the right word there. Well, thank you all so much for this featured presentation. It has been very helpful. And of course, everyone can access this when it is uploaded onto talk.crisisnow.com. And of course, Vikki, I believe your contact information is in this presentation as well, correct?
Yep, thanks so much. And thanks,
Yep.
Tom, and also for your remarks, very helpful.
Thank you.
Thank you all, thank you. So we are going to turn it to and keep us moving forward. So if we move forward here in the slides. We've got our crisis trivia hot seat. And I believe, Tom, are you in the hot seat this week? I actually think that you may be.
Ooh, I didn't know that if I am.
Matthew Goldman this week.
Oh, I'm so sorry. Well, see, you get a break, Tom, right?
Ooh.
Like I thought we were doing double duty.
Close
So
one. I was going to go to mute just to protect
Tom,
myself.
I don't know.
No.
Yeah, I think David mentioned these questions are going to get harder and harder. So Matthew, you were on the spot. I think you let him know that he wouldn't be able to get you, but this question got quite a few of us. So the question this week is, on February 16th, 1968, a red phone rang in the police station, but that first 911 call did not include geolocation or the ability to kind of precisely indicate where a person was. Early wireless integration was a challenge. So a tragedy occurred in blank year that led to changes with the FCC requiring wireless carriers to pinpoint precise locations. And so when we say precise, we mean X, Y, and Z. You've got a number of options here. Let us know if you'd like to pull up the poll. Here we go. We're going to get audience feedback. Audience, please put your thoughts on what year it is. This one's tough. I will say I did get it right. No pressure, Matt.
I'm already scratching my head. I'm trying to think out loud here. So it was, maybe I'm dating myself here. So I graduated college in 2008. And I remember I had my first cell phone in, I think, sophomore, junior year of college. So that's when cell phones were really getting out there, when cell phones would have been more widely distributed. So I'm leaning towards C or D, but definitely interested in the wisdom of the group. Okay,
Right.
So if it's either B or C, and I was saying C or D, then maybe I'll split the difference and give C a try.
All right, interesting. Well, let's see what the correct answer is.
Oh, even more
Yes.
recent.
Yes, it was actually 2014, which doesn't seem that long ago, but we've made leaps and bounds in cell progress since then. So this was actually based on an unfortunate story in Atlanta where a woman's location was not able to be properly pinpointed. And I think the 911 call initially went to the wrong PSAP location to begin with. And so following that, there was a requirement from the FCC around providing X, Y, and Z access location information. As we know, when we talk about 988 and geolocation, this is really from the standpoint of making sure that we're routing contacts to the correct crisis center best serving their area, and not necessarily about kind of dispatching someone, but making sure that if we do need to dispatch someone, that we have their precise in their location so that we can keep them safe. So thank you, Matt. I think we stumped you. I will let David know that he got you and he broke the streak. But we'll see what we do next week.
Thanks for having me.
No worries. So at this point, we're going to turn to Stephanie Hepburn to talk about the article in this week's Crisis Talk.
Thanks, Laura. So this week I spoke with Ebony Chambers. I know Ebony has to hop off the line pretty quickly, so I'll be brief. She's the Chief Family and Youth Partnership Officer at Stanford Sierra Youth and Families, and we chatted about how when a child is in crisis, so too is their family. Ebony, if you're still on the call, you mentioned that a child's crisis can't be addressed without addressing family dynamics. Can you talk a little bit about what that means?
Sure. Yeah. So, when our family was experiencing crisis, it wasn't just my daughter at the time. It was the entire family unit that really was kind of thrust into crisis. And so I really just want to ensure that, when we're thinking about crisis, we're defining it that includes whole family approaches and ensures that the caregivers, siblings, extended family members are included in a comprehensive plan of support.
I love that. Also, if you don't mind touching really quickly on the peer parent support, I thought that was incredibly unique and really important for people to hear about.
Absolutely. So at Stanford Sierra Youth and Families, we're in California. We have about 40 peers, both parent partners and youth partners that have lived experience, that have navigated the mental health systems and are working with families to support them in navigating those systems because we know how complex those systems can be. And so when a family is experiencing a crisis or in need of additional layers of support, a parent partner and youth advocate are assigned to that family team, as soon as they're entered into our care of services. And so they help walk alongside them, ensure that they're connected to resources and supports, but also just a source of hope and recovery from our own lived experiences that we've walked through ourselves.
Thank you so much for hopping on the call. I'll send it back to you, Laura.
Thanks.
Thanks, Stephanie. Thank you, Ebony. The link to this article has been placed in the chat. I highly recommend everyone go take a look at it. Thank you. If we go to the next slide and keep us moving here, I'm going to turn it over to John Palmieri, our partners at SAMHSA, for an update.
Thanks, Laura, and thanks. I appreciate the emphasis on family engagement in crisis and the framing around family involvement. I think that's really a really important piece. Just wanted to sort of flag one thing for today's update, and then I'll pass it off to the other members of the SAMHSA team. But there is an upcoming webinar on March 22nd at 2:00 Eastern Time, sponsored by the Action Alliance, that addresses aligning the field around a 988 messaging framework. And as many of you know, we at SAMHSA have been getting lots of questions about messaging and communication. SAMHSA and Vibrant have been working with the Action Alliance as part of a 988 messaging task force. And the work of that group has resulted in a messaging framework, which is due to be released next month and will be the focus of this webinar. And the framework will really serve as a roadmap, is intended to serve as a roadmap, really of key elements to consider when planning a messaging strategy around the transition to 988, and really designed to provide some general guidance to the field around when and how to develop public messages. So I'll throw the link to that webinar in the chat so that people have sort of broader visibility into that. And then I'll turn it over to Richard or James to see if anybody else from the SAMHSA team wants to add any other updates.
This is Richard McCann. I'll just add two things. First off, I loved Tom Insel's framing around the role of the crisis call centers, the crisis contact centers, right? As that it, not being, solely like 911 dispatch, but being telehealth and being first responders. I think that was certainly an excellent and important and accurate framing. The other piece of information, just like let people to know, is that in the just issued suicide and life-threatening behavior for this month includes a SAMHSA-funded evaluation study with Dr. Madeline Gould as the lead author, and that focuses on third-party callers and imminent risk. So I'd call your attention to that. While the dispatching of police or EMS is relatively rare in general, it is a bit higher for when there is a third-party caller. That's one of the significant findings. And there is at least the possibility with 988 that that there could be a significant increase in the number of third-party callers, not only calling about suicide, but calling about other issues as well. So I would certainly call that important piece of research to your attention. So that's all from me, John.
Great. Any
Thanks,
other
Richard.
SAMHSA?
I think we're good, Laura.
Yep.
Oh, James, did you want to say anything?
I was just going to briefly, I know a lot of people were engaged in some convenings that we had earlier, and one of the things that came up most critically was workforce needs specifically. And I just thought it was an interesting point earlier that, a lot of this has transitioned since pre-COVID, a lot more virtual and remote work possibilities. A lot of the centers and the organizations are nowhere where they used to be as far as their modeling. So if there are additional impacts or models that are out there that are working well in these times with recruitment, hiring, and just the transition that has occurred over the last few years, we would love to know about it and to be engaged into tracking those more closely. So that's a point of engagement that we're going to be focusing on internally in a place that we can gather more information from all the critical partners that are on the call today. So thank you. That was it, John.
Thank you. Back to you, Laura.
Great. Thank you, John, James, and Richard. Really appreciate all of the work that you all are leading. And thank you for funding that study. Very important. So grateful for our SAMHSA team. So at this point, I think I'm going to turn it over to Arlene Stevenson, who's the senior advisor with NASHBID. And she comes to us today, not only as a senior advisor, but with over 30 years experience with the state of Maryland in mental health issues. So Arlene, the floor is yours.
Thank you, Laura. I wanted to tell you folks about the 988 model bill. And for those of you who are not familiar with it, it is a bill that started in the spring of 2021, where we developed a draft template for states to use when they're drafting 988 legislation. And it contains basic ideas and language that a state can use, but also the idea is for them to take it and adapt it to suit their needs. The draft was shared with stakeholders. We had some very good input and made the changes. And in the early summer of 2021, we distributed it to the states. I can tell you, having read, I think, all of the bills, the majority of the states have used it to varying degrees. So recently, we began working with stakeholders again to create a 2022 update. And we're adding a few things to it. You'll see there on the slide for more information. And we are very close to making it available. So we'll let you know as soon as it's ready. Also, the next slide, please. We're also working on a 988 legislation paper, which is, of course, related to the bill. We've been working with the Lifeline to develop the paper, and the paper is titled States' Experiences in Legislating 988 and Crisis Services Systems. So it covers both of those areas. It includes bill summaries and status. It talks about the unique aspects of some of the bills, which are actually pretty interesting. It talks about the financing methods and the obstacles that they've encountered, and also provides some information where we could get it on the interface between 988 and 911. Right now, it's under work for graphics design, and so it should be released soon. I also wanted to mention there's a companion paper coming. It's on 988 financing, and that speaks to some of the financing options that were discussed earlier today, as well as what action states are taking with regard to 988 financing. And that paper is also coming soon. Thank you.
Great. Thank you so much, Arlene. And I know I am, as a policy person, just so grateful for the work that you all at NASHBIT are leading this space here. The model legislation has been immensely helpful, and so eager to see that used in the 22 session as well.
Thank you.
Okay.
Everybody here has been helpful.
Oh, thank you. So if we now turn to Sarah Corcoran, who's going to give us an update on what's going on federally.
Thanks, Laura. If we could switch to the next slide real quickly. First, as Laura mentioned earlier, it's been another busy week of congressional hearings on mental health. Yesterday was that second panel in the Senate Finance Committee on Kids' Mental Health, and then tomorrow is the Energy and Commerce Oversight and Investigation Subcommittee hearing on mental health as well. So that's rounding out February, where we'll have been 5 hearings on mental health in Congress. So it's a pretty exciting month that we're wrapping up here. And then in the fiscal year 22 appropriations middle band here, we are currently on a CR continuing resolution that will run out on Friday. Friday evening, midnight into Saturday is when it should be running out. The newest CR is in the Senate awaiting passage, and it looks like the lift has been, the hold has been lifted on that. So hopefully they can get that passed and signed into law before the midnight deadline. And it looks like the 4 corners of the appropriations committees have reached agreement on top line numbers and then specific allocations, what they call 302B allocations, to each of the subcommittees under the overall appropriations umbrella. So that is coming along, and a good sign that they will have been drafting bills and now up until now, and now they're kind of specifically going to be fitting those into what allocation each appropriation subcommittee gets. So hopefully we'll have more information about what the FY22 appropriations numbers for mental health and substance use funding will look like closer to the end of the month into the beginning of March, where that CR that is under the Senate right now will be extending to March 11th. So we'll have a little more time to get that full omnibus done and over the finish line before the CR that's being contemplated now would run out. That's it for me.
Well, that's it. That was a lot. So thank you, Sarah.
Thank you, Laura.
5 hearings in 1 month on mental health is a lot for Congress. So I just also want to recognize that for people who may not be familiar. So lots of great conversations and activity, and hopefully we can see lots of action. So if we go to the next slide, I'm going to turn it over to Hannah Wazalowski from NAMI to give us a state update.
Great. Thanks so much, Laura. Hi, everyone. A few quick updates for this week. We have a new bill in Rhode Island. That's HB 7389. This bill follows NASHBID's model bill, which Arlene just talked about very closely. It would allow the State General Assembly to assess a 988 fee. So we'll be watching that. Kansas, that's a state where we had legislation last year that didn't quite get over the finish line. That bill is back, HB 2281. That bill does include a fee, and it was heard in the House Health and Human Services Committee yesterday. We expect to vote on that today. The bill did, as drafted, include a 50-cent fee. There's still some debate and discussion about the amount of that fee, but we'll keep you all posted. Hawaii's had a bunch of bills. HB 1665 passed out of the House Committee on Health and Human Services and Homelessness that has 988 infrastructure definitions, but does not have a fee. And then there's 2 other bills that include a 988 task force and appropriation for the Hawaii Cares Crisis Helpline 988 transition. And then one last thing I'll note is Illinois' SB 2945 sets up a 988 trust fund. It does not set a fee at this point, but does set up that trust fund for future opportunities. It's set for a Senate floor vote. I believe yesterday I checked the legislature website right before jumping on, and the results of that vote weren't posted, but we'll let you know next time what happened there. Those are the big updates right now. Laura?
Great. Thanks, Hannah. Just really appreciate the work that you and staff are doing on this. And also wanted to give a big shout out to Kansas and the work being done there by advocates on keeping that bill going from last session to this session and still having a sustainable fee mechanism in there. Just also wanted to make a note here on this slide that you'll see 1, 2, and 3 highlighted for Washington, Nevada, Utah, and Virginia. Those numbers correspond with the crisis stat cards. And so I believe Utah, you're seeing some come across your screen now. We are trying to add additional states. And I believe Kim Myers from Utah, you may know which state is next to be highlighted on a state card. I'm not sure if you want to come off of mute and let us know if you're with us today. No worries. If not, the other item I will see, I believe Representative Orwell is with us today and wanted to see if you wanted to come off mute and talk about what's going on in Washington. I know you put a little information in the chat, but I know there's a lot of good stuff happening there.
Well, thank you. I'm really proud of the work our state's done, and thank you for helping shine the light of where we need to move our system. And, you know, I think there's incredible planning. I have a 911 bill, and we're really trying to figure out that relationship between 988 and 911. How do we set up protocol? How do we do co-location? You know, making sure we're actually working together as we move forward. And we're looking at, and I was so pleased on the marketing, like, how do we begin to explain this? And we're really looking forward to the advice you have for us. We're starting to look at signs and emblems for license plates. And, you know, again, we want to move, we know it's going to take 2 or 3 years to move our system. So how do you explain 988 and explain where we are today and where we want to be in 2 years? During this session, we're protecting our fee. We're very proud we had that. There's a bill to repeal it, which we hope does not move. Because those dollars are moving out to our call centers, and we expect they're going to double in size. And we're especially interested in that texting and chat room expansion. We have so many youth in crisis, and we have to get that up and running. And so our state agencies are working hard. I'm really pleased we got the 911 and 988 partnerships going. And I have to tell you, the Medicaid's tricky and we really need your help on this. And so we're looking at other states' examples. And so those are some of the pieces we're working on, and we're listening and we're learning. So thank you.
Well, thank you, Rep. Orwell. I mean, I think we're all in the same boat, learning and listening from each other. And that's why the Crisis Jam is so phenomenal, because you can take a little nugget from here, the license plate idea. I see some agreement in the chat. And just making sure that we are having sustainable funding so that we can have and build out the workforce that we need, the infrastructure and the capacity, and ultimately all of this in service of people who are in crisis. So thank you. The other thing I'll note briefly, the Vibrant team on the state side is expanding. And so some of you all may also be hearing and meeting from my colleague, Jordan Pantalone. So just if you see an email from him, that's the Vibrant team as well, working with the states to provide technical assistance. So let's keep moving here. All right, so this is the well, I won't say the last week. I think next week is the last week. I'm not sure where we are in the month of February. But just a reminder for the national survey on mobile crisis teams. And then see if Matthew Goldman, if there's anything you wanted to add about the survey, feel free to come off mute and let us know. He may not be with us at the moment, but again, you have until February 28th to the end of the month to complete that. And please, it's really important for us to have this information. So really thankful for Dr. Goldman and Preston Looper on this, as well as SAMHSA and our NASHBID partners. All right, Paul, turning it over to you.
All right, well, I don't have a lot of updates since last time. I did just post in the chat, though, that the tool is available. Those of you that have used the Crisis Resource Need Calculator, you know it's designed to give you a framework to project crisis cost, crisis demand, crisis flow. And McKinsey and company are doing some amazing work. So in the next month or two, we'll be able to introduce a new product that will go a whole lot deeper. And yeah, there's a quick visual of what's to come. It's really exciting and should be coming soon, Laura.
Great, thanks, Paul. I know we will all very excited to see that. That's also been really helpful in informing state legislative activity. So thank you for that. If we go to the next slide. Looks like we have a quick question here, Paul. I'm not sure if you want to get to it, but Margie is asking if we will see the assumptions like we can with the current tool.
Oops, am I showing there?
Mm-hmm.
Yeah, so all the assumptions have been published in NASHBID articles. Some of the discussion is in the national guidelines. And of course, McKinsey and company is also preparing on it will be more of a dedicated website, which will have more detail. So you're not going to be forced to, I suppose, go through articles to find them. But yeah, all the assumptions have been included. And in fact, a fairly large number of those, all of them are on the www.crisisnow.com website. So we do talk through those.
Perfect. Thank you, Paul.
Sure.
So also wanted to highlight the Moving America's Soul on Suicide, episode 3. And episode 3 features Tanja Miles, who we heard from last week or 2 weeks ago. And her story is just so compelling. So Karen has put in the chat a link to the website so that you can watch these episodes. They're very moving and highly encourage folks to take a look. Okay, next slide. All right, we've got our upcoming schedule. We are jam-packed as always. And so next week, you all will be hearing from Dr. John Franklin Sierra on Systems Engineering 1-on-1. And again, when we're building out and connecting the crisis continuum as we are for the 988 vision, systems engineering is just so important. So looking forward to that future presentation. And then coming up, just some items I'm going to call out here. Of course, you know, we've heard about marketing. So we have the 988 Communications and Partner Toolkit in April 27th. And so that will be really helpful. Again, we've talked a little bit about children's mental health and children's crisis care. So that's coming April 6th. Just lots of really great information here. So stay tuned and join us every week, as always, on this Crisis Jam. So I believe that is our last slide. Looks like we're right at 1 o'clock or maybe a few seconds before. Just wanted to thank you all for your participation, joining us today. Thank you for sharing your ideas in the chat. And thank you all for the work that you're doing.